So I think it's not that simple or straightforward. Looking on the guidelines that doing an MRCP, it would have been very different if the patient comes to you with jaundice. You get a basic CT scan. If you are not clear with the biliary anatomy, on a CT, probably you go for a MRCP. The patients need biliary drainage. You add endoscopic cholangiogram as well. So I think that is where we need to actually come up, that what is the best way forward.
Yeah, and I totally agree with you, Faisal. And I think that's what as surgeons we always deal with. Pre-operative, I call it geographical staging, where exactly the tumor is located. Because we use frozen section at the time of surgery just to help us if we have achieved or not resection or not. But shall I open this question for comments from the floor, from people who can help surgeons reach that pre-operative staging to help make our decision better regarding surgery?
I mean, I just want to add to your, frozen section is a different entity. You are going to cut the tumor, you have already made a decision, you are into the surgery, and you cut the bile duct where you feel the tumor will not be there. And you are actually trying to look for the microscopic extension. And microscopic extension is well known beyond the border of the tumor as well. So I think that is a different thing. What we need to decide about is the extent of the biliary disease, biliary extension before going for surgery. So what is the best modality?
No, totally agree. And any comments from the floor?
I think discussing about this particular case, we need to realize that this patient has just had a recent intervention, and we need to know, I think we should consider that these interventions cause trauma and inflammatory response. So if we take out this stent now and restage that tumor, you probably will overstage it because of the swelling the stent has caused. So I think if we have to discuss restaging it, probably then you have to think, do we allow enough time after the removal of the stent, and whatever that is, 2-3 weeks, and then image, and are we happy to wait for that long when this is a resectable disease? So I think it's a dilemma, and we don't have a clear answer on this. So going back to the initial recommendation that has been discussed this morning as well, that any intervention should be done after a liver center NMDT review, and that is the important. That this case highlights the importance of that, because now there is a stent, probably there is a hematoma or inflammatory response, or both present. So taking it out, doing further procedures, and then still not having a clear answer is the problem. So, but in this case, I guess it was difficult to assess, but in our future practices, probably we should not jump to drain these straight away after we, it should only be done after we have properly staged it and we have discussed those findings.
Dr. Harry, would you like to comment on this?
Hi, thank you very much. Very interesting discussion on this particular case, highlights some important issues. First of all, I think we're all having this discussion about this particular patient because something that should never have happened took place, and that's intervention before definitive cross-sectional imaging. And then the problems begin after that. The second point I'd like to make is it's a very unusual request to us by surgeons to actually perform a diagnostic ERCP for the purpose of accurate measurement of the length of the perihilar stricture. And because I think in this particular scenario, the risks probably outweigh the benefits. You have to understand that we probably need to inject contrast in both sides of the liver. We probably need to inject contrast in parts of the liver that will remain undrained, even with bilateral stents after the end of the procedure. And that is a recipe for disaster. So we are asking for trouble. So I think in most cases, even the best of cholangiograms probably would not be significantly more informative than a good quality MRCP or a good quality pre-intervention CT, high resolution CT. So we probably have to accept that we have to go to surgery with a reasonable degree of uncertainty, and that might be an acceptable option. On very few occasions, I've been asked to very accurately map a perihilar stricture, which has been standard or not standard, because it was important for the decision making. And I think this is the case where, after an MDT discussion, you have to go all in. And I think the modality that gives you a very accurate mapping of a perihilar stricture is spyglass cholangioscopy. It's not without the risks. I mean, it's the risk of ERCP that we mentioned, plus the risk of a very, very sort of bulky accessory traversing a stricture probably, but with combination of direct visualization and fluoroscopy, seeing what your spy scope is when you're actually seeing a specific image, you can very accurately map a perihilar stricture, but you have to wonder in which patient would that actually make a difference in the decision making. So in very selected cases, that would be probably an acceptable plan. Thanks.
I think if your CT is high resolution and you see a mass on a CT scan and bile duct dilatation on both sides, where you can, like in this particular case, you can clearly see where the bile ducts are actually normal and where the bile ducts are actually obstructed. For such a case, in my view, you don't need an MRCP, you don't need a cholangioscopy. If this patient did not have any mass, and you just have a biliary stricture, probably this is a case to go in for a direct spyglass and taking a biopsy of the stricture or by brushings, whatever is possible. Atif, do you want to add about just having a CT scan and looking at mass? I mean, our experience with the radiologist has been absolutely beautiful. I mean, we almost most of the time, especially if there is a mass, we know this is a cancer.
Patients with the sole investigation of CT scan, where there is mass is clearly visible on the CT scan.
Yeah, and I think the scenario that you're describing, that's perfectly fine. A CT will tell you the right anterior sector, posterior sector, if they're isolated. It shows that very nicely. The problem arises when it's a stricture type, it's a periductal infiltrating type tumor, where it's not reaching up to like 3A. There, in those cases, we can underestimate the extent of the tumor. In that case also, the MRCP will not help you. There is some data which says the MR may be better to show that enhancement in a longitudinal fashion because of its inherent contrast, better contrast resolution.
I just wanted to make only a comment. I think this is a fair question which Faisal raised. I mean, these are diagnostic dilemmas when we face day in, day out. We don't know what is the extent of the disease. I mean, the thing is, then we are playing most of the times when the patient reach our OPDs and they have already been drained, ERCP, stents and all that. And that further complicates the situation. We don't know what is going on. I mean, whether this is the inflammatory thing, whether this is the tumor or what. So then, I mean, again, a good quality CT probably is the mainstay and complemented where they're like MR findings. So that's what it is. I mean, if there is a tumor and there is a kind of, but one side is involving the hilum and the other side is spared, coming out and forming, not even going to the second order ducts, then I think it's a fair case to kind of go in surgically and get the best out of it.
I'm Rizwan. I'm from Liverpool. I'm HPQ physician there. I work along with Hassan. I think in Liverpool, we have a very established practice of management of hilar cholangio, perihilar cholangiocarcinoma. And almost in all cases, I mean, there's not one modality which will help to stage the disease. I think it's a combination of modalities which will help to come to a conclusion. And in our practice, we feel that the ERCP and cholangioscopy has a significant role, and our surgeons are very happily for us to perform on vast majority of the cases,
for establishing the extent of the disease. B, for tissue acquisition, which is crucial in establishing the diagnosis before you take up these patients for a very high risk surgery. So I personally believe that, and we have a data to show that, which supports this practice.
Historical data presented today and even yesterday, we are talking about a subset of a patient who did not have a mass, they just had a strictures, was assumed as cholangiocarcinoma and went on to have resections. And that ended up in 15% of the cases, they were benign. So this is a specific set of a patients with no mass, just a stricture, and has been considered as cholangio and got a surgical resection. And 15% of those were benign. Does that specific set of patients with the 15% negative surgical laparotomy make a case for doing cholangioscopy for every cholangiocarcinoma? I mean, that is the what inference I'm getting from you, that every patient having a cholangiocarcinoma, even if you can diagnose it on a CT scan, should be put through a cholangioscopy and a biopsy?
No, I don't think so. Everyone should have. I think
Okay.
it should be in a selected group of cases where there may be some diagnostic uncertainty. If there's a clear-cut mass, enhancing, radiology is happy, there's no need. But I take your point. It should be on a case-by-cases. But I say most of these patients ended up having some form of biliary intervention for tissue acquisition, mapping, staging, and preoperative drainage.
So we move away from staging. I have a question for Abdullah. Very nice talk about portal vein embolization and right hepatic vein embolization. Apparently, from all the data you showed, it has a significant benefit on the future liver remnant and the function of the liver, which is going to remain. But what is the cost? Like, not cost in terms of economical. It is important in Pakistan, but towards the patient, are we risk of more complications to the patient? Like portal vein embolization itself has been there for a long time, but if we are adding middle right hepatic vein embolization, are we increasing the risk to increase the future liver remnant, or is like it is safer or a safe procedure? That's number one. And another question: most of the data about portal vein embolization is the total liver venous embolization is about the colorectal liver mets. So in cholangiocarcinoma, do we have enough evidence to support? Because the surgeons are worried about the rapid spread of the tumor and they don't want to wait. In colorectal mets, we are somehow protected by the neoadjuvant therapy in term if we have a synchronous met, or a adjuvant therapy if we have metachronous mets. But those chemotherapies doesn't work very well in cholangiocarcinomas. So do we think we should be considering those in our cholangiocarcinoma patients as well? Thank you.
I think all these patients will go through an MDT, and only the ones who the MDT agrees will come to us for portal vein embolization. And again, you have to outweigh you have to consider the risks and benefits. And I think if you have got a less than optimal future liver remnant, I don't think we have much choice there, that you can't proceed with surgery straight away. So I guess benefits outweigh the risk in that. And in terms of your question, in terms of increasing the risk, I think they do, in our experience, they do surprisingly well after portal vein embolization. I mean, portal vein embolization, I mean, next morning you go and see, and they are either having breakfast or reading newspaper and no issues. With hepatic vein, again, I mean, no additional comorbidities as such. I mean, you will have a bit of a transaminitis, but that will settle. In settings of colorectal mets, you can argue if we have done an extended liver vein deprivation, then you're kind of limiting your future options because they keep popping new metastases. But in this setting, you probably will be okay because you just need an accelerated FLR hypertrophy and improvement in the liver function. So I think if you compare it with the ALPS procedure, you have got a lot less comorbidity and mortality in these patients who are quite unwell already. So again, I mean, going back, I mean, there will be some who will be suitable for surgical options, but as long as you choose your patients carefully, I think these patients will do fairly well. And the data proves it that there is a significant reduction in the post-surgical complications in patients who have had a portal vein embolization.
Yeah. Thank you very much.
Thank you.
One comment,
I've been
please.
asked by the organizer to use my power as chair of the session to close the session now. So we can interact with all the speakers who are present here and ask them questions, but Hassan Malik is not here. So any questions directly from Hassan Malik, who is online right now, before we close the session?
Or any comment from the Dr. Hassan Malik?
Yeah, comments plenty.
Right. Okay. In that case, I think we had a Hassan. Yes, Hassan. Any comments from you?
Yeah, I think pre-op diagnosis is crucial. A mass doesn't automatically mean cancer. We've seen some inflammatory pseudotumors. Yes, it'd be good to get tissue. The one thing perhaps hasn't been discussed is the role of liquid biopsies and how these can be incorporated into our MDT decision-making when getting tissue is challenging, despite spike loss and everything else. So that might be something that comes in the future, certainly. Look, surgery for cholangiocarcinoma is basically two things, okay? It's about removing the whole cancer, so that's about getting a negative margin and not killing the patient in doing so. And that's about having enough feature remnant liver volume and dealing with complications and things. So if you can get that right, I'm sure you'll do well.
Okay, thank you very much, Hassan. And with that, we conclude the session. We had a wonderful discussion. Thank you very much to all the speakers, and thank you very much for everybody listening to the session. Thank you.
Thank you all. There's a lunch break for faculty. The lunch is ready on the third floor. And yes, sir. So if you're requested to please come after half an hour, after 45 minutes.
I think we're going to be okay if everybody is here at 2 o'clock sharp so that we can start the session at 2 o'clock sharp. Break is till 2.